Good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I'd like to welcome you all to today's webinar. It's hosted by Salient Healthcare, and it's titled CCM and PCM, Netting Higher Patient Outcomes and Increased Financial Incentives. And they're going to explain all of those acronyms and what everything means. If you're new to this, and if not, there's going to be a lot of great information here. So very excited to hear from them today. A few items of note before we begin here. Everyone's joined today, as usual, in listen-only mode. So don't worry about your mic. That's been muted for you. However, if you would like to ask a question, then you can do so. And we hope that you do through your attendee module. There's actually a question area there. So not the chat, but there's actually a question place where you can put that in. We'd love to hear from you. You don't have to wait till the Q&A in order to submit that. We will have a Q&A toward the end, but go ahead and submit your question at any time. And if we're not able to get to your question today, then we're going to make sure to follow up via email afterwards. Someone will get in touch with you, but hopefully we'll have enough time to hit all the questions today. And then finally, the webinar is being recorded, so I'm going to afterwards send out an email to everyone who registered, even those who aren't in attendance, and that will have a link to the recording, as well as a place where you can download the slides and visit their exhibit booth, which I'll tell you about. And so we should have you hooked up there. So without further ado, let's get started here. Our presenters today are Miss Amy Koch, who's the Principal Business Consultant with Salient, and Miss Maria Nicole, who is Senior Business Consultant, also with Salient. All these guys are with Salient. And then Mr. Ryan Mackman, who is a Business Consultant and User Engagement Lead. So very excited to hear from you guys today. Ryan, I believe you're kicking us off, so I will turn it over to you, my friend.
Thanks, Garrett, and good afternoon, everyone. I'm Ryan Mackman. I'm a business consultant with Salient Healthcare, and I do want to welcome you to today's webinar about chronic care management and principal care management. I'm going to go over some of the things that Garrett just did, just a few items of note. Through ACO Exhibit Hall, I do want to inform everyone that this webinar is recorded, so if you do have to drop off, you'll certainly have the opportunity to re-watch this session, and you can even share it with some of your colleagues if you want. Both ACO Exhibit Hall and Salient Healthcare will email you a link of the recording and the slide deck within a few days following the webinar. I also want to mention that during the webinar, you can submit questions to other presenters and myself. You just use the attendee control panel, and then we'll answer as many of those as possible during the Q&A towards the end of the session. Just keep in mind the questions are being recorded too. So in the event that we're unable to get to yours during our allotted time frame, we'll certainly make sure to follow up and answer that via email. Now, presenting with me this afternoon, we have Amy Koch. As Garrett said, she is Salient Healthcare's Principal Business Consultant. We also have Maria Nicole. She is our Senior Business Consultant, and my role, as Garrett said, is Business Consultant as well as User Engagement Lead. Now, as consultants at Salient, we act as the liaisons between our clients and our developers so that our solution properly aligns with value-based care rules and regulations. This, much like many of our other previous webinars, have been put together based on our combined experiences. Now, with regards to chronic care management, what we've discovered is that a lot of ACOs could stand to benefit from CCM and PCM initiatives, but sometimes they have trouble launching these programs. What we're going to discuss today is why care management is a real opportunity for your organizations to make a significant impact with regards to both quality of care and helping the bottom line. After you see just how important a care management initiative is to ensure better outcomes for patient care, we then invite you to tell us whether or not you may have tried to launch a CCM or a PCM program, and we can discuss any challenges that you might have encountered. Okay, now it's time for my analogy. So for those of you that have been to several of our Salient Healthcare webinars, you know that I try to start off with an analogy for each topic. And I do that because I think it really helps to drive these points home. My analogy for this afternoon is that CCM and PCM programs are really like different types of nets. Depending on the type of person that you want to enroll, that's going to determine which program you want to implement. Not all nets are created equal. In this case here, you see we have a common fishing net on the far left for smaller fish, or if you have butterflies, if you have kids that like to run around in your backyard and catch those, In the middle, you have a pool net designed to collect leaves and insects that are floating along the surface of your swimming pool. And then on the far right is a casting net, and that's going to be used by fishermen to catch large groups of medium to large fish. And you have to know what you want to do before you select the correct net for the task at hand. And as what you're going to see now with both CCM and PCM, they're designed for patients with chronic conditions. But the number of chronic conditions, the type of condition, and the type of provider rendering services are going to determine which program you're going to want to enroll your beneficiaries in. The reality is that a lot of medical practices are performing some type of chronic care management already, but that doesn't mean that it counts as true CCM. Chronic care management programs were created by CMS because they knew that the Medicare population typically lives with several chronic conditions at one time. In fact, 3 out of every 4 Medicare beneficiaries have multiple chronic conditions, and Medicare fee-for-service beneficiaries with multiple chronic conditions account for 93% of total Medicare spending. So what that tells us is that up until now, those with multiple chronic conditions haven't been managed as well as they could have, and many of them could use a little extra effort. CMS recognizes CCM as a critical component to primary care, so much so that while some physicians had already been doing it, they can now be reimbursed properly for their efforts. When you look at that middle statistic there on the step chart, you can see how important that CCM programs are to the Medicare population. Now that you're being properly reimbursed, it's equally important to your organizations. The improved care coordination from a well-run CCM program significantly improves patient outcomes, and it really impacts your ability to achieve shared savings. Historically, both CCM and PCM are relatively new. I was still working for a large patient-centered medical home back in 2015 when CCM came out. We actually went so far as to hire an RN specifically to provide CCM. While it wasn't always easy to get patients enrolled, and I would attribute some of those challenges to the fact that a lot of patients didn't even understand what a CCM program was, the ones who did participate showed a marked improvement. Now, with regards to PCM, that's even newer. It started out just last year, and I'm going to differentiate that on this next slide. Remember that I said depending on the type of patient you're looking to catch, so to speak, is going to determine the type of net you're going to want to use. So now what we need to know is which net is chronic care management. By definition, both CCM and PCM programs are aiming to assist patients with chronic conditions, but they're not the same thing. Maria's actually going to elaborate even further upon this in a little bit. CCM and PCM programs are aimed to develop goals and interventions for patients with multiple chronic conditions by way of care planning. Now, when I explained this to some of my primary care physician friends, they said, okay, so how is that any different than concierge medicine? And then we're just there for our patients no matter what. And the thing is, concierge medicine is there for your patients that want high touch frequent access, can be there for pretty much any reason, and have the means to be able to pay for it. The CCM and PCM programs are there for those beneficiaries that need it and will benefit the most from it. Many other commercial programs will also pay for this as well. Speaking of who's going to benefit most from it, my next slide here speaks exactly to the benefits of care management programs. The reality is that everybody benefits when ACOs implement a CCM initiative because patients get appropriate quality care. You also have providers that are implementing their relationships with their patients, and then the organization benefits when you implement a CCM initiative because it leads to improved care coordination and cost savings. I'm going to break these down individually here. We're going to start with the patients because really patients should always come first. Chronic care management has been proven to promote independence. I think that alone is worth a lot to most patients because one of the biggest fears as people age is the loss of independence. Just anecdotally, my father is in his 70s. He just gets angry at me when I come over to change light bulbs or do anything that requires a ladder because he feels he should be able to do that himself. Improved independence means that they have improved mental health, which then improves overall patient health. Physical health improves just from the high touch frequency care, and CCM programs significantly augment the patient-physician relationship, which is going to reduce the trips to the hospital, or at least convince the patient to call their PCP before immediately rushing to the hospital for something major. Now, I mentioned that we implemented a CCM program in my former role, and we did that exclusively through telehealth services. Now that telehealth is all the rage, they've significantly expanded access to care for patients, especially in the time of a pandemic when people are fearful of coming into the office in person. You also have to take into consideration that many patients may not have transportation services, but with CCM used in conjunction with remote patient monitoring and telehealth, the patient can receive ongoing care from their primary care provider. Okay, moving on to the medical practices. What you're going to see is that by supporting patients during high stress times, like during the pandemic, primary care providers are able to strengthen the patient-provider relationship. Now, this allows providers to be thought of first and to be available for the patient when the patient needs them the most. CCM services, coupled with remote patient monitoring and routine health visits, allow patients to get access to their primary care provider, while the provider then receives additional fee-for-service revenue, which makes it a win-win. And then finally, the benefits to the ACO. If you're decreasing acute care utilization, you're increasing patient satisfaction through high-touch frequent visits, and you're improving your quality scores through care gap identification. Honestly, it's pretty tough to find a reason not to implement a chronic care management program. Okay, now I know I promised we'd hear from our other presenters, so I'm going to go ahead and hand this off to Maria now, and she's going to dig deeper into more specifics on CCM services. Maria?
Yeah, thanks, Ryan. So let's take a deeper dive into what is required for CCM services. There's actually two types of CCM services, basic and complex, with various reimbursements and additional codes for additional time spent. CMS has already started to recognize the importance of addressing behavioral health issues and social determinants of health.
Hey, can I step in real quick? Ryan, I don't think you're sharing your screen anymore.
Sorry about that, guys. That was a technical difficulty on my side, but Ryan, you should have the reins again here to share. There we go.
It was Garrett. Sorry,
Yep.
Maria.
All right.
Okay.
So let's talk about the basic CPT code for chronic care management, which is 99490, which requires the patient have at least 2 or more chronic conditions, as well as documented consent to enroll in the program and receive at least 20 minutes of CCM services from clinical staff within a given month. A personalized care plan which shows the goals and interventions is also required. Now, the add-on code for basic CCM is 99439, or previously G2058. Now, this code allows providers to bill for each additional 20 minutes of time spent for basic CCM services in a given month for up to 2 times. So let's look at an example. If CCM services were provided for at least 20 minutes and then an additional 20 minutes, making it 40 minutes in a given month, and it was not complex, then you're going to bill 99490 for $42 and then 99439 for $38, and they'd be billed together for that month. Now, please note that this is the average reimbursement of these codes, and actual reimbursements may actually vary depending on your region. Effective January 2019, a new code was added to the CCM group of coding reimbursement for physicians and clinical staff time for non-face-to-face care to qualifying Medicare patients, the 99491. This code is really similar to the original CCM code of 99490, which was introduced in 2015. These CCM services are to be provided by physicians or qualified health professionals personally. And this code requires 30 minutes of CCM care in a given month and pays an average of $74. For complex CCM patients, CMS offers the CPT code of 99487, which has a higher rate of reimbursement than the basic code. To bill this code requires moderate or high complexity in medical decision making and an acute exacerbation. And that generally means that the patient had a sudden worsening of their condition that necessitates the additional time and resources. The patient should receive at least 60 minutes of services from clinical staff time within the given month. There is an add-on code to cover the additional time beyond the 60 minutes. So let's take a look at an example of how that works. So if 90 minutes of complex services are provided in a month, then you would bill the 99487 for $93 and the 99489 for $45 for that month. Now, again, this is an average reimbursement of these codes, and actual reimbursements may actually vary depending on the region. In addition to the CPT codes for basic and complex care management services, CMS also offers one behavioral health code that could be used by primary care providers to bill for behavioral health services. And that code is 99484. To qualify, the patient must have at least one behavioral health condition and then receive an additional 20 minutes of behavioral health integration from either clinical staff each month. It also requires separate enrollment and consent and a separate care plan. The average reimbursement of that code is $45, but again, it can vary depending on your region. The physicians and the APPs listed on this slide may actually bill for CCM services. And while CCM is most frequently billed by primary care providers, specialty providers can also do so in certain circumstances. The CCM services is not within the scope of practice of limited licensed physicians and practitioners like clinical psychologists, podiatrists, or dentists, although practitioners may refer or consult with such physicians and practitioners to coordinate and manage care. And for codes 99491, the time spent by the billing provider only counts. For codes 99487, 89, and 90, the time spent by the clinical staff and the billing practitioner count towards that threshold since they're assigned general supervision. And general supervision means that the service is not personally performed by the billing practitioner. It's performed under his or her overall direction and control, although their physical presence is not required. So as Ryan had pointed out earlier, 70% of Medicare patients with 2 or more chronic conditions are eligible. However, these chronic conditions don't always place the patient at risk for death, acute exacerbation, decompensation, or functional decline. It's really strongly recommended not to enroll 70% of your population into CCM services. The purpose of CCM services is to assist patients with chronic conditions to optimize their health through care coordination, which will decrease exacerbations and unnecessary hospitalizations. Providing CCM services to patients that are well managed is wasteful. And remember to always provide services that are only clinically appropriate and clinically necessary. And don't forget about those behavioral health issues and social determinants of health. These patients benefit greatly from that increased access to care and the additional support outside of the office visit. So CMS identifies the key care plan components that you're going to find listed here. I'm not going to go through each one of them in detail, so you can always refer back to the slides and take a look at them later. However, I did want to highlight a few key areas of focus based on my personal experience. The care plan is really key. It serves as a roadmap for what the care coordinator and the patient are going to work towards, both from a goals and intervention standpoint. And remember that patient engagement is really key if you're going to drive behavior change. And many practices use motivational interviewing as a key component of that behavior change. One of the easiest things to do is actually print the care plan for the patient. Not only is that a program requirement, but it helps with patient engagement. You may even consider printing it each time that the PCP has an appointment with the patient to ensure that everybody's on the same page. I'm now going to go ahead and hand it off to Ryan to take us through the sample workflow, and then Amy and I are going to provide some color commentary throughout.
Okay, thank you, Maria. So what I'm going to do now is I'm actually going to discuss a CCM sample workflow. And in order to demonstrate how this is a team-based approach, I'm going to make this a team-based slide. So the very first thing that you're going to want to do in order to get a CCM program off the ground, identify patients that are good candidates for CCM. Now, Amy, would you mind telling us how to go about doing that?
Absolutely. So basically, Maria stated it before, you do not want to enroll 70% of your population. You need to be really selective of who you're choosing to enroll because you're not going to get that return on investment. Basically, a lot of doctors saw this in the initial output in 2015, and they saw the $40 reimbursement, for each of these patients, and you can just right off the bat calculate how much you could make off of this. But this isn't a fee-for-service type of program. This is the long game, right? This is a value-based care type of program. So you'll reap benefits in savings by not having those acute exacerbations. You do get a little bit of fee for service so that you can get this program running, but I would think of it more as like infrastructure payment as opposed to making up for the whole program. I do want to point out that when you're trying to figure out who to enroll, you need to start out with pilots right off the bat and do pilots by chronic condition because you have to think through the chronic condition in its entirety. If you're doing, say, a diabetic type of program, think through adding dietary and exercise and all of those components that you want, and then really execute it. Create that small cohort of patients who understand that they're being enrolled in this program and really walk them through front to end and see how well it does. Then kind of elaborate from there. So be really specific. I don't think there's anything else from there. Maria, do you want to add a little bit more?
Yes, I really agree with everything that you just said, and I want to focus in on and make one additional point is that you might want to focus on that small cohort of patients, and especially those with either high ER or hospital use. And don't forget to select patients that might have behavioral health components, for example, anxiety or depression. And as Ryan had stated earlier, it's really a team-based approach. So the entire office can participate in patient identification.
Yeah, absolutely. I helped implement it at a few different offices, and we even got the front desk staff who could see the patients in the waiting room involved, because then they can identify some of those patients who might be, fall risk, and they most likely have multiple chronic conditions. So they kind of ID'd them, handed a little sticky note off to the nurses, and then they had that discussion with the patient once they realized this might be a great candidate for CCM. So getting everyone involved from the front of the office all the way through the end when they see the provider, and then mentioning it again to them. So like reiteration at every single point is really key.
Great, thank you. Now we're going to move on to phase 2. And here in phase 2, you need to focus on patient engagement. Now, I don't want to say that this is a sales job, but to some degree, you're going to need to sell your patients on why they're actually good candidates for the CCM program, and then what that program entails.
Yeah, absolutely. And you know what? The easiest sell is honestly to patients who had a traumatic experience, people who already were admitted to the hospital who never want to go back, right? That's like a no-brainer. If you said, hey, I'm so sorry about the whole situation, you were in the hospital, but we have a high-touch program, we're going to talk to you on a regular basis. I mean, who wouldn't sign up for that, especially as a Medicare patient? You might not be living with your whole family, right? So having that interaction is a much easier conversation. I would never recommend force feeding someone this program because, they also have to pay a portion of it if they don't have supplemental insurance. So it's not that difficult of a sell if the patient really needs it, and they'll know why too.
Yeah, so in addition to transitional care management visits as being a really good way to engage patients and introduce them into the program, the annual wellness visit is also another great opportunity. It really allows you to spend time with that patient, start the care planning process, and make sure that you're on the same page regarding the overall course for the year and making sure the patient stays out of the emergency room in the hospital. And you can use that AWV or TCM as your sales opportunity.
Yeah, I agree. It's like it makes sense, right? If they've identified something happened, so in a transitional care management, they just came out of the hospital most likely. Perfect opportunity to enroll them. Doing a wellness visit and reviewing all those chronic conditions and then saying, hey, we'd like to do a little bit more intervention with you makes a whole lot of sense. So you shouldn't be having to pitch this too much. And if it is too difficult of a pitch, maybe they're not the right patient to be doing this with.
Absolutely. Okay, so we're going to move on now to phase 3. And here's where you're really going to want to draw up a care plan for each of the patients that you've then brought into your CCM program.
Yeah, so care plan is critical, and it needs to make sense, and it needs to be constantly updated. So you have your wellness visit, maybe from your initial, the IPPE, your initial onset, you have a care plan drawn up, and then it needs to be edited throughout the year as they're enrolled in this program. You're constantly advancing. I mentioned this before, I want to reiterate, CCM does have some cost sharing with the patient. So it's really important to have that discussion with them up front, because if they get a surprise bill, that's kind of the end of it. They're trying to trust you as your provider. So you need to have that conversation. Unless, of course, the patient has supplemental insurance, and that will usually cover it. So always be upfront with them, tell them all the details. Don't miss anything, especially when it comes to payment, because that can dissuade someone very quickly.
All right, excellent. Okay, so then we get to phase 4, and that's all about completing the actual care management. Here's where we're really in the midst of doing what needs to be done for the patients.
Yeah, so first and foremost, I just want to state that completing care coordination is a full-time job. And depending on the complexity of the patients, you're probably going to have a care coordinator working on 50 to 70 patients at any given time. Most of the time, the care coordinator is going to be a registered nurse, but I've certainly seen pharmacists and other staff perform these services. But remember that there's really an ROI component to this program, as Amy had touched on before, and you're going to need to pay that staff. The best engagement that I've seen is when you reach out to the patient on a weekly basis rather than doing that 20 minutes at the end of the month or once a month. And remember that while the clinical staff is providing these services, these programs are really completed under the supervision of a physician. So physician engagement is really key, especially when it comes to review and oversight. Another interesting point is ensuring that your practice has coverage when a care coordinator takes time off. Who's going to be doing that patient outreach? You want to make sure that there's at least 20 minutes of time with the patient on a monthly basis. So let's say that they go on vacation at the end of the month, and wouldn't it be a shame if they had done 19 minutes for those patients and you couldn't bill for all the hard work that you had just accomplished?
Yeah, that would be pretty terrible. You are providing services, and CMS does have some of those requirements, so you should be able to audit that time. I do want to talk about some of the little tidbits that I've picked up while helping to implement this program. So I highly recommend getting involved with community resources. I know equity, health equity, social determinants of health are buzzwords, but they're really used in CCM. This is the main use case. Identifying patients who can't buy their medications, who don't get meals. Meals on Wheels was one of the biggest community resources we were able to use. Or even just activities, people couldn't walk. So getting them to walk to their mailbox, and then getting them enrolled in maybe a church where they had morning walks. So kind of involving the community is a great place for the ACO to have that community recognition, because you're a healthcare setting in a community, but also recognizing that these are health factors, right? They're going to impact the person's chronic condition if they can't do certain things like that. I also wanted to talk about consistency in communication. Maria touched upon it a few different times, but reiteration of this is key. If you're implementing this in an office and the actual doctors are not on board, it's not going to be successful. You need everybody totally on board and supporting it and asking, how is the program doing? Because you just need that reiteration. And consistency in communication with your patients is important. One of the things we recommended was to have a specific notepad right next to the phone. So every time they had a phone call with their nurse, they were jotting down questions or notes right there. And then the phone number for their nurse was always on the fridge, so they knew exactly where to access it. And just knowing exactly where that information was important to keep consistency in that relationship. And then Maria touched upon it before too, but reiteration of how to engage the patient a little bit more is bringing their care plan. So have them bring a care plan anytime they have in-office visits, because that's kind of cyclical. It's, you know, they're having telephonic visits through CCM, but then sometimes they're going to have to come into the office for a wellness visit or something else, and make them bring it in, because it's showing that things are happening, things are moving along, and they're always reviewing it whenever they print it out. So I think it's important to like keep that communication alive and get feedback that way.
Okay, thank you guys. And I guess that brings us now to the final phase. So that's the point of graduation. And I think that a lot of times, those that are new to CCM, they think each patient remains in the program indefinitely, but that's not true. There's a graduation point, and that's typically around the 6-month mark. But you can adjust accordingly based on the patient's goals and complexity. Once a patient does graduate, then they move back into the regular patient pool. Just keep in mind though, should the need arise in the future, you can always re-enroll that patient into care management. All right, now I'm going to turn this over to Maria.
Yeah, so Amy, Ryan, and I had just reviewed the best practices based on our experience of implementing the CCM program. Wanted to reiterate how important all of these are, so we've created a checklist for you to take away after this presentation.
Yeah, and it's helpful to kind of run through these components. I also want to draw your attention to the final piece here, which is needing a tech solution that's going to help you complete the entirety of this program. So you can't do this with manual chart review. I've seen it done because I helped implement a program back in 2014, and they were just kind of new to all of this. So basically, you need something that's going to quickly cohort your patients. You need compliance documentation. That's kind of the whole point of the program in getting those reimbursements, because otherwise you're just doing a whole lot of work and effort and just not getting that fee for service in return. And then, of course, the calculation of your ROI. Your CFO will never let you run this program if they don't know that something is actually happening long term. So really figuring out what's going on, what's that continuous process improvement cycle looking like for this particular initiative.
All right, so now we've reviewed the CCM basics, I wanted to talk about principal care management. So first, why was PCM developed? CMS had recognized that clinicians across all specialties manage care of beneficiaries with chronic conditions and created new codes for principal care management, or PCM services. PCM is for patients with a single serious and high-risk chronic condition. CMS stated in the final rule that they expect that the majority of PCM services will be provided and billed by specialists focusing on managing patients with particularly complex chronic conditions that require substantial care management. The expected outcome is to be able to stabilize the patient by the specialist so that the overall care can then be returned to the patient's primary care practitioner. Specialists really wanted to provide care coordination services, but the CCM codes were intended to be primarily used by PCPs and select specialists like cardiologists and nephrologists. So CMS created the PCM code to allow more specialists to complete care coordination. So to qualify for PCM, the patient must have a diagnosis that's expected to last at least 3 months or until the death of the patient, may lead to a recent hospitalization, and or place the patient at risk for either death, an acute exacerbation, or decompensation or functional decline. Now, although CMS didn't propose any restrictions on the specialties that could bill for PCM, CMS expects that most of these services are going to be billed by specialists. So, for example, the PCM program really lends itself well to urologic conditions. My husband is a pediatric urologist, and he's considering implementing this program for his patients. This is going to include the coordination of medical and psychosocial care related to the management of a single complex chronic condition like voiding dysfunction. So similar to CCM, we've created a cheat sheet that identifies all the codes, the associated reimbursements, the time requirements, and who's going to care for that patient for the PCM services. The care plan components and the workflow are going to be really similar to the workflows that we've reviewed for CCM services. I'm going to go ahead and pass it to Amy to do a demo of how to identify patients for both PCM and CCM and how that data can be used to determine the effectiveness of the programs for your organization.
Thanks, Maria. So Garrett, this is where I'll need the ball passed to me.
Okay, one moment here.
It's always risky doing a live demo, but I'm gonna do it. Show screen.
We need some cool holding music for everybody.
I think we, let me know if you can see everything.
There we go, we got it.
Okay, stunning. So what we're looking at right here, let me just do full screen. Okay, brand new Salient dashboards, yay. They're to be released, I think the beginning of next year. But what we're looking at specifically is our CCM analysis dashboard. And I think of CCM, PCM, even remote patient monitoring as a sandwich, because at the front, you need to identify the best patients for the program. Like we said before, do not enroll everybody, don't do this. Just because they're eligible, that is not the way to go. You need to be specific. You need filters. You need to set some rules to create those cohorts. So that's kind of the front end of this program. Then you have the middle piece that's actually running the program, you know, taking notes, having the nurse have those communications and editing that care plan. And then you have the end of it, which is, am I successful? How do you calculate that return on investment? So what we're looking at here is that front and end of it. Here we have a tab, it's called Care Management ID. This is where you're gonna find cohorts. Based on the criteria that you wanna start with, you can do it by a number of ways. So we can look at it by risk. I never recommend CCM to be done on the sickest of the sick. They always find, you know, studies show, I think I can find one from CMS, you know, doing this type of program on the patients who've already hit stop loss is just not good use of time. Those patients require very specific type of care. This is more for that rising risk population. You'll probably want your medium high to medium population. So you can just double click and drill in on who that cohort is, and everything will kind of update for you on the screen. And then, like I mentioned before, maybe you want to start off with a pilot and do a specific chronic condition. Now, each TIN or practice, or even if you go by NPI, are going to have a different makeup of their population. So go with the one that's most prevalent for them. So pick your chronic condition. Maybe it is diabetes, you know, something of that nature. So really narrow down your cohort. Maria talked about enrolling patients with high acute care utilization. So maybe throw in a rule there, like having 3 or more inpatient visits or 4 or more ER visits. And then, of course, this rising risk, rising cost of patients, that whole concept. So the patients who are at $100,000, those are the sickest of the sick. But maybe it's the people who are trending upwards that you really need to capture to push them back down. So it's maybe those who started at $10,000 that went to 15, that went to 35. Those are people that are slowly or incrementally increasing that you want to capture and enroll in this type of program. Now, you could always use other filters. You know, we know for CCM, they have to have 2 or more chronic conditions. So apply a filter for 2 or more chronic conditions. It should be easy for you to create this cohort. You shouldn't be manually combing through EMRs. You know, it's nice to just be able to see all your information and capture it in one place. You know, easily apply a filter. These are all my people. I might want to start with these guys right here who have high utilization of ER and IP plus all the other factors, you know, so you can really narrow it down. Then comes that ROI part. Let's talk about how you want to view it. We have a few components here on the screen. We're starting with that nice CFO bit, right? It's how much money are you making in fee-for-service revenue? So you can just see right off the bat that there is some money to be made. Of course, if you work in a hospital and it's RVU based, you want to make sure that this is aligned properly for the payers so that the fee-for-service dollars that are actually coming into the organization match up with how you're reimbursing your providers, because this should be incentivized type of care. And then down below, we can actually see who are the providers rendering the services, how much, and is there a change in the ER, IP, and total dollar amount? Because that's what we're looking to do. We're looking to improve acute care utilization and spend. And if you have someone like this demo data shows, Dr. Whitaker's physician group is doing a ton of services, but they're all in the red. They've increased acute care utilization. They've increased spend. This is not what we want to do. So let's revisit that CPI process. It's probably identification of patients because they probably just enrolled whoever would enroll, and now they have poor outcomes, right? We're trying to get the program to be successful. You want to enroll the right people at the right time. So these are all the components that we bring to the table. And of course, there is the care management module. That's that meat of it. That's the RN comes into the system. They're plugging away at the care plan and managing all that care. So that's kind of that meat, and it'll link you over to that module. So those are the Salient dashboards, specifically for CCM and PCM. And I'm going to hand this back over to Ryan.
Okay, I'm going to try to take control of the screen. Let me know when there we go. And Amy, can I get a thumbs up? Excellent.
Yes.
All right, so thank you, Amy, for showing the care management component of our brand new Salient Healthcare dashboards. One thing that I do want to touch on is that Salient also provides a comprehensive resource library, which you're seeing here, and there you'll find additional CCM and PCM initiative documentation, as well as workflows, and also a copy of this presentation. We want to make sure that we take away as much of the heavy lifting as possible, so it's definitely worth the look for that reason alone. Our website is www.salienthealthcare.com. We also have all kinds of additional literature available on the website if you'd like to see what else is in there. Now, for those currently attending that are part of an MSSP ACO or a DCE, just know that we offer a free 45-day trial with your own data, and we can even run an assessment for you. So if your organization is looking to implement a CCM or a PCM initiative, we can certainly see if that's an area of opportunity and then help you get that started. All right, now I'm going to open up the floor for some Q&A. So if you have a question for a specific person, let us know. Otherwise, we'll just assume that it is general. Garrett, do you have any that you can read off?
Hey guys, yes, I am back. Doesn't look like my camera is working here. Oh, hold on. Was it working? Okay, I'm just seeing a black screen. Okay, so yeah, we did have a few questions coming in, so let me just go ahead and ask these in no particular order. The first is, for the provider who is rendering services, does that vary by state?
Yes, I'll take that one. The requirements for PCM and CCM don't vary by state, so it varies by code. And we had discussed which providers and clinical staff could bill each one of the codes earlier in the presentation.
I will say though that your makeup of your practice is going to vary by state based off of if a nurse practitioner can run their own office and the like. And I think it also makes sense to really figure out who's running your CCM program. Maria said, she's seen pharmacists run programs like this, and you might have other clinical staff. I think it's important to just kind of figure out how much is it costing for them to do this type of program, and how much are you being reimbursed, and where do you see the cost benefit there? I think it's good to analyze that.
Great. Okay, next question here is, how do you involve your specialists into your care management, and what is your recommendations?
So I'll go ahead and take that one. Obviously, they can do PCM services, as we had just touched on. So that's an obvious, opportunity. The other way is with care coordination. So if you are the primary care provider rendering services, you can certainly involve and coordinate with the other specialists that might be involved, as well as community resources, as Amy had stated earlier.
Yeah, in the beginning of the ACO program, I think people were skeptical about how to include specialists. And I think this code really brings it back to the picture. It's like before we were kind of just saying, you're going to get volume. We'll just treat you like the fee for service world, and you'll just keep getting patients because if you're compliant with what the ACO needs, which is getting notes in a timely fashion, making sure the patient comes back to primary care, those were kind of the tit for tat type of relationships that I saw. But now it's like, let's get them into value-based care. Let's let them have their own program and be specific to their specialty and really involve them with this front to end type of care. I think it's really a nice way to engage them and show them that value-based type of care they should be providing.
Okay, great. On to the next one. We have tried to implement a CCM program, but got a great deal of patients declining. Is there a better way to encourage participation?
Okay, I'll take that one, guys. So that varies by person, but honestly, CCM's not for everyone, so you have to take that into account. Some people really need it for the sake of motivation, and then even then, a lot of times you might have to ask multiple times. One of the things that we do is have our CCM nurse make the initial phone call, but then we would flag the account if the patient said no. And then the next time that they came into the office, we'd have the provider that they're seeing bring up the CCM program again. And then at that point, right now, they've heard it twice, and they've heard it at least once from a provider that they already trust. So it often helps to have those two perspectives of the nurse and the PCP. A lot of times that second attempt is what coaxed them into the program because you have that trust and familiarity established by then. Our motto was basically 3 strikes and you're out. So if the patient said no 3 times, then don't push them anymore, but don't be afraid to ask more than 1 time initially.
Shouldn't be surprising that Ryan has a sports phrase for everything, considering his backdrop there.
I didn't even come up with that though. That was our office. So
yeah, that's a good one.
No, it is nice. And I also mentioned earlier the transitional care management visit when a patient has just come out of a traumatic experience. It's not frequently that they're going to say, no, I don't want to have some sort of care that'll prevent me from going back to the hospital. It's like, it should be a no-brainer. No one wants to go back there.
Yeah, no, this is all good. Okay, next question is, we do have several more that came in here, and in no particular order. Let me know if any of these are repetitive, and if you've already, spoken to this point. Does Salient work with any direct contracting entities or DCEs?
Yep. So during, the PI period, we took a look at, IP, implementation period, right? We took a look at various data sets, which look very similar to the ACO data set. So you're getting lots of claims data, you're getting attribution and all sorts of, risk codes and the like. So I think if you were an ACO and you're pivoting or you're brand new to everything and you're a DCE, I think it's good to know that data-wise, you're not going to be missing a whole bunch. I think you'll be pretty surprised with how robust it is, especially if you've been involved in Medicare Advantage plans. Just comparing the amount of data is going to be huge to be a part of the DCE.
Okay. Great. And this next one, I'm going to paraphrase just a little bit. Is there benefit to cherry picking the patients like this, or would you agree that CCM PCM done right would allow engaged providers to treat in place or in advance of an exacerbation that translates into a hospitalization? I know that's a lot there. Did that question make sense?
It did, yes, and I would say it's picking the right patients. I wouldn't necessarily use the term cherry picking. It's identifying those individuals that are either at risk for an acute exacerbation or an event and preventing it before it actually occurs, or a future event that might occur. So you don't want to pick super healthy patients, and you don't want to pick those that are extremely sick. And I think that the dashboards that Amy had showcased earlier really help to identify which patients you might want to put in these programs.
Yeah, and the same individual here mentioned also, wouldn't the sickest patients represent the highest potential savings? And I would think that'd be correct.
So the sickest patients don't always mean the most amount of savings, because it doesn't always come back to zero, right? It's like these are patients with a lot of chronic condition. You know, it's going to be more than 2. It'll be like 6, 7, 8. Those are patients that need very targeted care. I would say CCM is more of like a lighter version of that targeted care. These are the people that can get better, that can go from being way above your benchmark to coming in underneath it. That's your wiggle room. It's the people who've already hit stop loss are the patients that aren't going to get that much more healthy. Those are your ESRD patients. They need very specific targeted care, way more above and beyond what a CCM is reimbursing you for. Maria, I don't know if you have anything to add there.
Yeah, especially patients with very complicated cancer diagnoses, for example, those at the end of the life might not be appropriate for CCM. You might want to consider other programs, and there are other programs out there. There's disease management programs that might be a little bit more appropriate for them. And that's what I've seen done, especially with payers in the past, is really using this as a stepwise program.
Great. Next question is, and we've got a lot more coming in, so we'll get to as many as we can. Can the provider organizations forgive the copay in order to get the patients to join and comply?
No, I don't think you can, but I know that supplemental plans will cover it. And then I think there are some other programs out there for, I think DCEs get it, where you can do like gift cards. So for annual wellness visits, you can give a gift card. And I think there's kind of ways around it to make up for it a little bit. I think you can get creative because you can give patients incentive for doing population health like activities.
But be careful, Amy. I think the gift cards can only go up to $25. I think that's the cap.
Yeah, something like that.
Yeah, very good. Okay, next question is, can the 20 minutes for the month be a combination of several different clinical staff? Say 15 minutes with a nurse, then 5 minutes with the practice pharmacist?
Yep, absolutely. So the clinical staff is a combination of staff. So as I had said earlier, for example, if somebody's going on PTO, for example, then somebody else needs to be able to take over that care planning, as long as, again, you're providing that value to the patient for the month.
Yeah, CMS is reimbursing you for a team-based approach. I think they heard that note and took it to heart. So if it requires the full team to help out, I think, you know, they're going to reimburse you for that.
Okay, great. A couple real quick last questions here, and then unfortunately we need to wrap up. What data are you using for your ROI calculations? And is CCM outcomes or implementation of SDOH, or social determinants of health, and outcomes or something else? I don't know if that last thing
It's a
made
little
sense.
coded. Okay, so I think what's best or has been best used is claims data to get that final ROI, because those are, you know, definite, written in stone what happened. So we're using claims for that ROI calculator. So you do have some claim lag, not as much as say some of our Medicare clients or Medicaid clients rather, but we are using claims to calculate the ROI. That middle piece of the pie, or sandwich like I called it, is clinical data. So that would be involvement with the EMR, really talking about the care that's going on, updating the care plan. That really requires the clinical data. And then for patient identification, we also use the claims data. What diagnoses were really submitted? What are those risk scores that we're calculating on a monthly basis using diagnoses and updated claims data? Yeah, those are basically those data points that we're looking to. What happens in that middle part for SDOH and stuff like that are the communications that the nurses are having with the patients. So a lot of times it's just by having a normal conversation. You don't want to have just any nurse doing CCM. They need to have personality and be able to form relationships with people. I always said, like, keep a sticky note, or if your actual solution has a sticky note function, to have it available up in the corner. And if someone says, you know, my son is going to be graduating from wherever, you know, you jot that down and bring it up and make it a part of the incentive to get better. And sometimes that's the biggest motivation. So using data that the nurses are collecting is really important to kind of have that bi-directional input of information.
Yeah, and obviously our Y calculator that we had showcased earlier has the financial outcomes in there, but there's always going to be those non-tangible benefits to the patient, which is that patient engagement, patient satisfaction, and the fact that the patients are really getting the best care. And there's always, you know, a lot of stories that come out of the care management programs where the patient says, I've really had a tangible benefit of this, and I wouldn't be able to do this without my nurse.
Very good. Well, guys, we unfortunately have to wrap up because of time. We do have questions that continue to come in, but which is a great problem to have. If you are one of those individuals, we will get back to you. Someone will get back to you to answer your question via email afterwards. So if you have a last minute question, go ahead and submit it before we wrap up here. As we close out, and I want to thank you guys so much. This was a very informative session, and it's a really, really important topic. I'd like to encourage all of you to visit the ACO exhibit hall and to visit the Salient Healthcare booth there. It's a place where you can engage with the team, that you can download different materials, and actually this is also where at the ACO exhibit hall in our libraries where you'll have access to the recording of today's webinar. So in all of Salient's webinars, as a matter of fact, you can search for webinars, but I'll be sending it out to you along with the slides afterwards. So let's move along to the last slide here. And thank you guys so much again for joining us today. If you want to contact any of our speakers today, here is their contact information, and feel free to reach out to them. Thank you so much for joining us, and I hope you join us for the next one. Thank you.